our day for today. This event is being recorded, so this will be available to you to share with others or visit again in the future if you want. I'm really pleased today to have our webinar, our continuing medical and pharmacy education session on making the connection, the local and national perspectives on public health data exchange. If you go to the next slide. So my name is Tom Agresta, and I do want to let you know that we do receive funding for putting this series on from our State Health Information Exchange, CONI. It provides the funding, but no influence over the content of the program. If you go to the next slide. And this is part of an ongoing CME and continuing pharmacy education series called Health Information Technology for Clinicians, How to Achieve Optimal Outcomes. We do have some webinars and in the future hope to have in-person events. They have not occurred because of COVID in the past. From the Department of Family Medicine and the Center for Quantitative Medicine at UConn Health. And if you go to the next slide. This is the series actually looks at a number of different things. I believe this is topic number 10 or 11 in the series. We've done webinars on medication reconciliation and safety, on telehealth, on image sharing, on precision medicine, health information exchange, and today we're getting and on patient-generated data. And today we're getting into the public health informatics arena. If you do have any ideas for good topics in the future, please feel free to reach out to us. Our contact information will be at the end of the presentation. We go to the next slide. So today's learning objectives, we're going to try to define what disease surveillance is, some of the standards that are required to kind of share data. We're going to describe what's required if we're going to exchange public health data, both from the standpoint of some technology as well as sort of governance around that. And then obviously we've had COVID to teach us an awful lot about what works and doesn't work and provide us with an opportunity to learn further. So we're going to talk about lessons learned from that. And then we're going to talk a little bit about what's being developed kind of for the optimal infrastructure in the future. So if we go to the next slide, we can do a little housekeeping. You all be muted during the session, but you do have the capacity to ask questions in the question and answer or chat sections. We will follow up with them and answer questions at the end. If for some reason a question that comes up that's really appropriate for us to talk about as we go forward, we will do that. If you are not able to address your question today, we will have our panelists and us put together responses and send them out via email afterwards. And today's session is available is being recorded and will be available afterwards. If you qualify for continuing medical or continuing pharmacy education, we'll give information about how to retrieve that at the end. If we go to the next slide, today I get the opportunity to kind of introduce a number of wonderful individuals to present today. We have Adi Gundlapalli, who is a physician informatician and a background in infectious disease, and also has a master's degree in biomedical informatics. He's currently the Chief Public Health Informatics Officer at the Center for Disease Control, inside the Center for Surveillance, Epidemiology, and Laboratory Services, which he'll describe a little bit more for us later in the presentation. And Adi previously was the Chief Health Informatics Officer for the VA in Salt Lake City. And then Adi and I have known each other for over 10 years because we served together in helping to bring forward the board specialty of clinical informatics. Our other panelist today is actually not going to be with us in person because she was actually called to present to the legislature of Connecticut at the exact time that we're presenting. So we had the opportunity to record her earlier this week, and we will be able to get questions to her. is Dr. Manisha Jutani. She is currently serving as the Commissioner for Public Health at the state of Connecticut, which she's done since July of 2021. So she got her christening in the middle of COVID. She is an infectious disease doctor and Yale trained in terms of fellowship, and she actually has an associate professor role down at Yale. And you'll hear a little bit more about her motivation for why she is doing what she does later in the presentation. So if we go to the next slide. This is one of the things that we try to do is try to understand a little bit from our audience, what is the most important things that we would like to, what do we believe the most important things we'd like to see from public health surveillance? And one of the things that we probably want to try to do is, ask your opinion. So I opened up this poll and you'll see it available for the next minute and a half. And when Adi is finished with his conversation, we'll get back to the responses on that poll. So please take a moment and answer your poll that should be open to you while we go to the next slide. And we'll have Adi introduce himself and go ahead and start the conversation.
Thank you. Good afternoon, everyone. First of all, a huge thanks to Dr. Agresta and the UConn team here that's putting on the webinar and the work that you've been doing, gosh, for a long time in preaching and really, increasing awareness of public health data exchange. And yes, thank you for the gracious introduction, Tom. The other connection is that I did my graduate school PhD and internal medicine residency at the University of Connecticut. So go Huskies is what I'd like to say to start us off on this. Again, thank you. It's an honor to be here as part of this webinar, and welcome and afternoon to all of you. Next slide, please. I'd like to start off with public health clinical example, and hopefully that'll set the stage for how we want to go and spend the next 15 to 20 minutes today discussing data exchange. Next slide, please. So we always, recently we've started with recounting a very powerful slide on testimony from Janet Hamilton, who at that time was Director of Science and Policy at CSTE, which is Council of State and Territorial Epidemiologists. Janet is now actually the leader for CEO for CSTE now. And this was this testimony she gave was in April 2019. So it seems like, in COVID years, that's probably 15 years ago. Though it's only 3 years ago in real time. And please bear with me while we walk through what Janet said. So data moving slower than the disease. And this was very prophetic statements in saying the nation's public health data systems are antiquated and in dire need of security upgrades. Paper records, phone calls, spreadsheets, and faxes requiring manual data entry are still in widespread use and have significant consequences, including delayed detection and response, lost time, missed opportunities, and lost lives. I mean, this could not have been more powerful. Having seen in the next 1 year, by April 2020, we were, in the thick of COVID. And I think Janet foretold all those with these statements. And that's what we're trying to get away from this, right? I mean, we still are in some silos exactly where Janet said, but I think we're in a much better place now with COVID and all the investments and the people that have gone into making it better. Next slide, please. So the example I wanted to give was really a huge, the complex public health ecosystem that we have in this country. And this gives you just the overarching highlight of that. This diagram is from publicly available diagrams on how CDC receives data on case-based disease surveillance. So on the left half of the diagram, you'll see this is where you all come in at the state and regional level and the healthcare level is when there's a reportable condition, example COVID, and monkeypox also in some jurisdictions is reportable, are required by local laws and regulations to send data to the local, regional, state public health authority. So on the extreme left are the hospitals, healthcare providers, laboratories who send a report, be it COVID or measles or any other reportable condition. And public health at the local level is the lifeblood of our public health data and ecosystem, and that's where all the action also occurs. So the folks here at the regionals are doing a lot of work to curate, collate, add value, enhance those electronic case reports, lab reports, health reports, etc., to put it into case, do contact investigations, contact tracing, etc. And also put those data in an integrated form into your own surveillance systems at the state level. And that is a challenge in terms of, silos within healthcare systems, within regional public health authorities, and then being able to add value to what comes in from healthcare. And then at the next step is where from the state, local public health authorities, it's a voluntary process by which the states actually send case notifications to CDC. So reportable conditions at the state, and those are notified to the federal government, to the CDC. And here we've shown that there's HL7 and a transmission process, de-identified data, of course, so that CDC does not know or will ever attempt to re-identify who that individual is. And then we have a lot of processing that goes on within CDC. The data are then sent to the specific program. So for example, sexually transmitted infection data will go to the center there. The COVID data goes to National Center for Immunization, Respiratory Disease, etc. And based on public health events, specifically such as COVID, we also have an obligation to send de-identified aggregate data to World Health Organization. So you can see that even though it starts at the heart of everything with the individual at the healthcare system, goes through the local public health authorities where action occurs, and then finally gets to CDC. So it gives you a flavor of how much, how many steps there are and the complexity of the system here and trying to make it all work at any given time. Next slide, please. So what I wanted to give you a flavor for today is how are we addressing these silos and these challenges through data modernization? And it wasn't without reason why I mentioned Janet Hamilton's testimony in April 2019. That testimony, along with others, was actually instrumental in providing the first funding for DMI, or Data Modernization Initiative, in 2019 from Congress. So we're ever grateful to CSTE and all our partners for their amazing, amazing work in advocating for modernization. So DMI, as we call it, was launched in 2019 with funding from Congress in collaboration with public health partners, funded by the CARES Act, and then later on during COVID to American Rescue Plan and dedicated appropriations. And we're working to develop and sustain modern, integrated, and real-time public health data and surveillance. So that's really what our mission and vision is for this. Next slide, please. We're not starting from scratch, and so that's very important to show that we're not starting from scratch. These are actually some of the national level public health surveillance systems that have origin in healthcare and then at the local public health agency that we already have in place. So for example, syndromic surveillance, that's emergency department visits from about 71% of the country are now funneled through to CDC so that we can look at it at the national, regional, and then sub-regional levels also. Electronic case reporting, which I'm very happy to report was in my portfolio and now has matured into a full-fledged program and transferred to another division at CDC. And COVID really was an energizer for electronic case reporting, which I'm almost certain Connecticut is also part of. Notifiable diseases, as we showed you the example of the NNDSS, or the National Notifiable Disease Surveillance System. ELR, or electronic lab reporting, has been there for decades, and is really a very important part of how timely and data get to local public health from laboratories directly. And then, of course, to bring it all together, Vital Records, which is managed by CDC at the national level through a National Center for Health Statistics, which is the arbiter for births and deaths in the country. So these systems have been there, have been functioning, have been slowly modernizing over the years, but this is an opportunity for us to work with all of you to be able to take this up to the next level. Next slide, please. So there some pillars of DMI, or Data Modernization Initiative, that I wanted to walk you through. Those are building the right foundation, accelerating data into action, and none of these would work without a state-of-the-art workforce, which is needed to run any of these systems. And we cannot do it alone, so it has to be done in support and with partnerships along with all public health agencies in the country, and both public and private partners. And this needs a change management also, because a lot of our silos, etc., are cultural. And so we need to be able to get across those. And overarching governance is also needed. In the next few minutes, I wanted to take you through a few of the points for each of these pillars for DMI. Next slide, please. So we'll start with this one, building the right foundation, and we'll go counterclockwise in each of these slides. So the first is looking at automated real-time data collection, and this happens in Connecticut and everywhere around the country. And we talked about those systems. So those are ECR, or the electronic case reporting, ELR, or electronic lab reporting, syndromic surveillance, vital records, and more recently, immunizations have become a real highlight. Prior to COVID, immunizations were restricted mostly to children, and capturing those and tracking those. Of course, adults had vaccinations, but those were really not captured in any regular or systematic format. With COVID, we changed all of that, right? I mean, think about 10, 20, 30 million vaccinations per year before COVID, and now we're talking, 575 million doses in the last year and a half or so. All these need to be recorded and need to be looked at national, regional, and sub-regional, at the state level, state and local level. But we don't want to put extra burden on our partners here. So trying to automate this is really very important. We've made good strides, but there's still more work to be done. So reducing burden and allowing data providers to turn off their fax machines, right? That was the highlight picture you saw over the past year in several media reports about fax machines and overloaded stacks of paper on them. To help with sort of putting this together at a national level, we're working with our partners, all of you at the state, local level, and our associations to look at what we're calling North Star architecture. So creating a collaborative vision to improve STLT access to actionable intelligence. STLT here refers to state, tribal, local, and territorial partners, which are all of you folks here. And so stay tuned for more on that in the next few months, where CDC is rolling this out in collaboration with CSTE and other partners on how can we have some sort of common architecture where we don't need to put data in again and again digitally. So once digital, stay digital. Reducing silos. So both at CDC, which is hugely siloed, just because of the way funding came in as line items, more than 150 line items for different systems, and of course at our partners, trying to see if we can migrate standalone systems to a common architecture. That's easier said than done, right? The technology and that is available, but it's really managing change, getting all our experts on the same page, and really cherishing the expertise, but looking at how can we do more of common architecture rather than standalone. And of course, moving to the cloud, which has been challenging over the years, but now is much better in terms of FedRAMP and security, etc. And so seeing if we can move many of our systems at CDC into the cloud, and also looking at cloud-based services at the STL. Next slide, please. So here, looking at accelerating data into action. I mean, we have big data now. All of you have seen that and deal with it at the state level and the national level. But all that morass and deluge of data is meaningless if we don't turn it into action. So again, going counterclockwise, starting with rapid outbreak response. Over the past year and a half, or gosh, 2 years now, for COVID, we've had to adapt and scale existing systems for surveillance for COVID. We've had to build new systems and really start thinking about what that common operating picture is that we can use. And so we've learned a lot. We've had to build the airplane while we were flying, along with putting the wings and the tips on there. But we've learned a lot. And so we're hoping to build on that and look at this common operating picture and prepare ourselves for the next pandemic. Gosh, there's really no respite for any of us, right? I mean, all of you are dealing with the pediatric hepatitis cases, and now the slow trickle, hopefully, which will stop, is of the monkeypox cases. So we have to be able to be agile and learn lessons learned from COVID, being able to expand into the next, whichever it is, epidemic, pandemic, or the national and international scale. The next is linking and opening data up. So nowadays, you just cannot depend on one data source or data stream. For example, lab reports. Just having a lab report is important, of course, for the positive test and the negative test, but you need much more context by being able to add value by adding demographics, by adding vaccine information, and then their healthcare encounters and outcomes. So trying to link and integrate data from diverse sources for more actionable insights. That too is easier said than done, because many times there are regulations and policies against linking data. And how would you link across data sets while preserving privacy? Because that is so important. The prime directive is to make sure that we respect privacy, confidentiality, and security of every single individual in the country. And then the points here about connected public health and healthcare data, which I think Commissioner Jitani will also talk about, and Dr. Agresta has been working for many years on looking at adopting interoperability standards, creating hubs for data exchange while protecting privacy and security. It's quite easy to say, let's collect all the data about X, and that X could be a lab result, that X could be about hospitalizations. But when you get down to brass tacks, the definitions of what that means is so important. And even if there's a minor change and we misinterpret or miscategorize one of the elements, and one of the people don't use the same standard, then we won't have interoperability. And that's so basic, but we still see it at every stage now that we have to talk about it. And it has to be a proactive stance, not a reactive after collecting all the data. And then recently, you may have seen in the news media, CDC, along with the rest of federal government, has started a Center for Forecasting and Outbreak Analytics, which is based out of CDC Washington, and is already about 100 or 200 people strong, and looking at not just finding passive and active surveillance that we count cases and look at it, but getting into the forecasting and prediction mode that we are not able to do while we're in the thick of any specific pandemic. Next slide, please. So here, I wanted to tell you that it's so important. You can have any of these activities, technology, cloud, servers, IT programs, but none of that will work without a state-of-the-art workforce. And so for us at federal government, it's very difficult to recruit and retain talent because there's so much need for public health professionals with expertise in data and systems. And so at the state level and in private sector. So we're trying our best to do a concerted effort for recruitment, and not just recruitment, but retention. We also have to work on forecasting workforce needs. Do we need more people with cloud technology expertise, more people with machine learning, more people with informatics, that kind of stuff. And so looking at all of those. And it's not just at CDC, all of you at the state and local level face the same challenges in finding, predicting what type of workforce we need. So supporting all of you is a very important paradigm for us, building a public health workforce for the whole country. Then, of course, training and what we're calling upskilling. So those who are already in public health, trying to keep them and prepare them for the next generation of systems, data, and data scientists, etc. Next slide, please. I think we're going to be in the last few slides here. Just tell you, we can never do this alone, right? So this has to be a constant and continuous engagement with state, tribal, territorial, local partners to address policy changes and solve problems. So there is a need for us to work on common policies because, as you know, in our public health ecosystem, policies and regulations change from state to state and jurisdiction to jurisdiction. So trying to find that common denominator is so important. Data use agreements. We, CDC is not the owner of the data, of the public health data that we receive. We are so grateful to our partners such as you in Connecticut and others who are allowing us to have access to those data. So we have to have robust and really good data use agreements so that we stick to what we're supposed to be doing with the data and how we can use them. And that's so important to maintain and to earn that trust and keep that trust with all of you. Collaboration. So not just with state and local jurisdictions, but with private partners also, academic, public health, and private partners in terms of industry. And if you pick any of the large names in tech in the country, we're very pleased and happy to be working with all of them to further the cause here. Through all this, we have to have transparency. So increasing access to modernization, the plans that we have, the progress, our vision, so that all of you are able to look at it, comment on it, and make it better is what we're looking for on this. Next slide, please. I think this may be the last one or two. So here, along with all of this, we have to have a way to provide the necessary support for adoption of unified technology, data, and data products. So governance. We have governance in place. We've had that for years, but it has to keep pace with technology. And so we're working very hard on looking at how can we have CDC-wide, agency-wide, and federal government-wide strategies and guardrails for how we can do these data investments. Change management, as I talked about early on, it's not the technology only. It's really a question of looking at the culture of innovation, collaboration, inclusion, and adaptability. Procurement, it's not always easy for federal government to procure and acquire services and products in a timely manner, and all of you know that. So trying to streamline those processes, especially during times of emergency, are very important. And through all of this, we have to have a very robust monitoring and evaluation arm of this because we need to question ourselves. You all need to be able to see it and say, how is the progress going or not, and how can we improve it in an agile manner as we go on this. So next slide, I think that may be the last one. Really, what does success look like? In all of this, we should not forget that we place huge burdens on our partners, such as you in Connecticut and all our jurisdictions. And our number one priority is to decrease burden on providers and hospitals by replacing those faxes and phone calls with automated reporting directly from electronic health records. We want to be able to free up public health staff time, both at CDC and the jurisdictions, by providing them the infrastructure, tools, and training to use data for more targeted interventions for their communities. And really have an awareness of emerging threats. So we are surprised almost continuously in terms of looking at one problem over the other, but is there a way to try and forecast some of these and planning and directing resources to prevent or even mitigate public health impacts of this? So the last slide, I think, is just a thank you slide, and I'll stop there and hand it over back to Dr. Agresta with a huge thanks for inviting me here, and a pleasure to visit with all of you. Over.
Thank you, Adi, and that was a wonderful perspective, and it gives us a sense for where we're headed in the future. But I know Adi has stepped into his role at the CDC, just a few months before COVID hit. So I'm sure that he had to pivot substantially from what he thought he was going to do. But this is good work that we're headed towards, and we thank you a lot for that. I am going to go ahead and just share the poll results with you now from that prior poll. So you should be able to see them now on your screen. And basically, of the 50% or so that answered the question, most people felt that the most important outcome is awareness of emerging health threats and disease detection and intervention. And that's not surprising given what we've just been through in our nation. But actually, a number of folks also looked at, insights into public health and using the data to predict and forecast, what may be coming. So the sort of analytics part of it and the prediction is also going to be important as we go forward. So if we go to the next slide. We're going to have a second poll that I will now open, and that is, what do you think that we should be sharing in Connecticut? And while this poll is open for the next minute and a half, we are going to be able to go ahead and start the process of actually having Commissioner Giuttani's recorded presentation kind of move forward. But as you do that, what public health data would be helpful to share in Connecticut? Birth and death records, infectious disease status, immunization status, other things. But go ahead and share your views on that. I will say that as we move forward to the next slide, and we can go to the next slide, please, that Commissioner Giuttani did record this earlier with us, and here to help answer questions is Miriam Miller, and she will be available in the question time afterwards. And she is a public health strategist and health policy associate at the Department of Public Health. And we're really pleased to have her join us after the question answering time. But that does bring up the opportunity for me to remind you that we do have a question and answer panel that you can kind of enter data into, and we will kind of then go ahead and answer the questions as we go along. Go ahead, Ryan, and you can play the recording. You will not see Commissioner Giuttani. We didn't actually video this recording. It will be an audio, and we'll play through the slides as we go.
Giuttani, it's wonderful to have you here and helping us pre-record this section of your presentation. As we know, you have to testify in front of the legislature on Thursday when we're doing this live, but it's really wonderful to have you here. And now I'd like to turn it over to you to begin your presentation.
Well, thanks very much, Tom, and for the invitation. And I'm very excited to talk to you about this topic today, because coming into infectious diseases and public health, I have trained in infectious diseases 20 plus years ago and have practiced in the field. But it was my love for disease surveillance, first identified by a case of typhoid fever in New York City, that we were able to track back to a source based on surveillance that really got me interested in public health. And now have the opportunity to serve as commissioner has been a great opportunity so far. So thank you for this opportunity. Next slide. So I would like to go through a little bit about how surveillance occurs in a Department of Public Health and some of the core systems that help support public health surveillance at the state level, and then goes back to the local level in our local health departments. So for example, you see on this slide a number of different systems that we have in the Connecticut Department of Public Health. And I'll give you an example, for example, of syndromic surveillance. So this is something that goes back and forth between the local health departments and the state. And we can see various different things that are occurring both in the emergency departments in hospitals on various different syndromes, whether it be things like influenza, COVID, or opioid use and admissions that are happening for that. And those are integrated in various different ways. As you can see here, we've got integrated disease surveillance, which is looking at a number of different infections that can occur, birth and death registry, the immunization registry, tumor registry. Our lab has an information system that communicates both with local health and with our hospital systems where data can be put in directly. Electronic data exchange occurs on a daily basis between all these different systems and the state. It's part of the way that we've been able to monitor COVID through this pandemic. The Connecticut Violent Deaths Reporting System, through which we have communication with the Office of the Chief Medical Examiner, where deaths that are violent deaths are put in on a daily basis. And again, we can get a sense in real time about how things are happening. And then lastly, the unintentional and undetermined intent overdose response system is another system, again, related to opioids and other things that we have real-time monitoring that helps us get a sense of what's happening in the state and be able to connect with local health departments as well. Next slide. So just as an example, I want to highlight the epicenter, which as a use case can help us understand what is happening, particularly, let's say, with the opioid crisis. So, for example, we have very close to real-time reports on emergency department visits from all 38 licensed hospitals in Connecticut. And that data is reported by a responder, a first responder on site into the epicenter system. And it's through this surveillance unit that we can get a pretty close to real-time indication of drug overdoses and related emergency department visits that are happening. So DPH staff, as you can see on the right side of this slide, is alerted within 24 hours if overdoses spike in a certain geographic area, which then relates to an initiation of an investigation. And this investigation is sometimes, as you may see in the public, then alerted to a given area that there may be a common source of overdoses that are happening. And this is how we are able to utilize these types of surveillance systems to be able to alert the public on how these real-time impacts of these types of situations are happening. Next slide. So I want to go through some of the different areas in which surveillance has its impact. And right now, I'd like to first start with our infectious disease section and our informatics program. So what have they been doing? They manage infectious disease surveillance and case management for nearly all reportable diseases and other needs that may occur. And this electronic data exchange for lab results goes both ways. So it happens from the local health department to the state, and then from the state to the CDC. And this has been highlighted through COVID-19 in terms of laboratory testing. So we've expanded from the state lab only to academic and commercial labs as well. And this was particularly true for PCR tests. As we all know, we are moving into a different realm of things as more self-testing is occurring in our state and throughout the country. But this expansion then occurred to pharmacies and mobile testing sites, provider offices, and then went on to include rapid PCR and rapid antigen tests as those tests came online earlier in the pandemic. In addition, there was also a provider reporting portal that was available, and this was open access where COVID-19 case reporting, so not just laboratory tests, but case reporting could happen electronically, where hospital infection preventionists were then asked to do direct data entry into our surveillance systems for hospitalized cases. This has really streamlined all of the COVID reporting that has occurred throughout this pandemic, and that will continue to help us monitor cases of COVID as they are occurring and the impact on our hospital systems. Next slide. So how have we been able to improve things through this pandemic? Initially, as you can see on the left side of this particular chart, we had about 3.5 staff members, program staff, and 1 IT staff member who was involved with data reporting. And through an entire year, we received about 390,000 laboratory tests for all diseases that we monitored as reportable diseases. And this electronic lab reporting for all reportable diseases occurred through about 3 hospital systems and 2 standalone hospitals. And we had no electronic provider reporting of tests or case reporting. But then COVID-19 happened. And so as much as we would have liked to plan for this type of reporting requirement, there became a requirement to make this happen in real time. And that's what happened. So as we now enter year 3 of this pandemic, we are up to 8 program staff, and we have 3 additional that are coming online to be able to deal with this type of disease surveillance, in addition to 7 full-time equivalent IT staff with 6 additional coming online. To give you some scope, we've had over 19 million COVID-19 tests reported to the State Department of Public Health, and that's just COVID-19. So remember, we are still likely getting about 390,000 of the regular tests that we would get for other reportable diseases. The 19 million COVID tests are what have happened since the beginning of the pandemic. And in addition to that, what has happened is we've had over 200 lab entities that have been brought online, and all but 2 are acute care hospitals, including now major commercial labs, all of which are doing COVID-19 testing, that have been brought online to this type of system. And in addition, we've had over 300 different institutions. So whether they're point of care tests, mobile testing, pharmacies, other COVID-19 testing locations have all been brought in. So you can see the scope of what type of laboratory testing, what type of infrastructure we've needed to build over the last 3 years. And one of the new things that really occurred as well was the development of data analytic platforms with data warehousing, so that data can be automatically pulled and available for analyses, in addition to case reporting that is now happening electronically. A lot of this was happening by fax and through other methods prior to the pandemic. And so this is how we have been able to report COVID positivity on a daily basis, COVID cases on a daily basis, and we issue a weekly report of all case surveillance that occurs with COVID-19. And really, the pandemic has forced the hand of the state, where we had to develop these types of systems in real time. And it is helping us overall because we have so many other diseases that are reportable that we now are able to capture on a regular basis through these platforms. Next slide. So another case example that I want to highlight is CTWiz. So what is CTWiz? CTWiz is a platform that was originally built and used to monitor vaccination status for children between the ages of 0 to 5, primarily for school entrance. And what happened with COVID-19 is that there was a federal requirement to report COVID-19 vaccines that were administered. And because CTWiz was already in place, it was expanded for our use to be able to track COVID-19 vaccinations for all age groups. And this is how the state was able to track COVID-19 vaccines that were administered. So the infrastructure was improved and allowed us to be able to provide many people, whether it be administrators of the vaccines, for example, pharmacies or other testing sites, other vaccine administration sites, but also to make vaccine data available to Connecticut residents for themselves. So this is for personal use, to be able to have access to their vaccine information. Now, whenever we talk about vaccines and whenever we talk about information and access to vaccine data, people often get concerned about their personal information and what may be available to the public or to other organizations that may be looking to monitor vaccines. And this was critical for our response in the pandemic. And what happened in this past legislative session is that this was able to be passed to now be permanent so that all vaccine information is available. And there are a lot of issues with communication to the public in terms of why this is safe, why it remains private, and bringing the public on board to make them comfortable with why information like this is necessary for public health surveillance is a constant challenge that we deal with. But we are fortunate that citizens in Connecticut are able to now access their own information to be able to get a sense of their own vaccine record. So for example, as people are, for example, going on to college, if they need that information to be able to put together a vaccine record of what they need, not only could they get it from their pediatrician, but they would have access to this type of data through their own record, their own private personal record. And you need to be able to access the system to your own system to be able to get that information. And that is one of the benefits of what has been passed in this legislative session. But this type of health information exchange is something that there are a lot of communication challenges around in order to be able to protect people's privacy and still allow health systems to also have a response and a continued response to this pandemic, which we are now able to do going forward. Next slide. So I just want to conclude with a couple slides about where we move forward as a state in this point in time, and specifically looking at our data modernization efforts that are occurring. So we are looking to build a private cloud data center and then have an exchange of data. But in order to do all this, we need increased staff in critical areas to be able to have this type of information exchange. And this will help us in terms of our partnerships with other state agencies, including our IT infrastructure, which is BITS, which is a statewide IT platform, and then the Office of the Chief Medical Examiner. As I mentioned, if we're talking about deaths that are occurring from COVID or otherwise, violent deaths as an example, to be able to have that type of infrastructure and to be able to have data exchange occur in as real time as possible, this is what we're looking to move towards and to build towards. And we are fortunate that we have CDC funding to be able to sort of build this structure. We built a lot in real time in order to respond to the pandemic, but we have so far to go. And it is over these next couple of years that we are hoping to establish this type of governance and enterprise framework to be able to allow for that type of data modernization to occur going forward. Next slide. So our progress on this so far is that we've identified what gaps exist in our assessment of our data modernization to date. But what we are now doing is looking to expand that and identify what our governance needs are, establish a champion for this, and that is what we are in the process of hiring at DPH for, assigning a specific DMI lead, creating a steering committee with participation from key program management staff to be able to create that platform and that communication within the agency. And we really need to think more about how are we moving forward with this? What is informatics? What is IT? And where do data scientists fall into that entire platform? And this has been an under-resourced area historically. We do not have enough staff in this area. Where we are fortunate is that we do have funding right now. But our challenge is going to be going forward. So a lot of the funding that we've received is through 2024. And this is where our legislative efforts nationally, particularly, continue to work towards to be able to gain funding from the federal government that is not disease specific, so not COVID specific, but that can be geared towards public health at large, because we are building the infrastructure to be able to respond to public health challenges going forward. But in order to do this, we need to be able to have the systems and infrastructure in place that can be long lasting and that we have funding for, reliable funding for going forward, so that we can maintain the systems that we have the funding to build right now. So we've had many conversations with the Connie team, the Connecticut Health Information Exchange team, and I look forward to seeing how it continues to build because it has really tremendous capacity for the public in terms of being a central source for health information so that as they go from one provider to another, that may not all be on the same system, where their health information can all be in one place and really help facilitate quality of care and care that occurs across different health systems. And as this system continues to mature and expand, I do see the potential for the department also working with the exchange because I think that there's more and more capability that will come online, both in terms of disease reporting and disease surveillance that occurs. I know that there are other states that are able to leverage this particular ability of the Health Information Exchange. And as our system improves and continues to move forward, I look forward to looking at how we can continue to collaborate on the number of areas that it is very capable in. So thank you for your attention, and I appreciate the opportunity to speak with you today.
I'm going to ask two questions. One, as you imagine, what you actually would want other partners in the state to do around, providing you with these resources or helping you, continue to have these resources available, what would you envision being helpful?
So one of the things that is a priority of mine overall in this job is workforce development. And workforce development spans the spectrum in terms of types of jobs that includes. And so, of course, it starts at the local health department and goes all the way through our department in terms of epidemiologists and other engineers, other types of professions. That also includes informatics. And there is a certain understanding that is required of, number one, the legislative and privacy concerns that relate to safety of personal information, and yet how certain information is critically important to addressing public health concerns. So I'll give you an example that so far we have had no eyes on knowing how many people in the state of Connecticut get vaccinated for flu every year. We have surrogate measures, but we have not had that so far. Now with CTWiz, we will be able to have a sense, aside from just COVID, but how many people are getting vaccinated for the flu every year. And for informatics people to be able to understand the privacy and legislative issues that govern a lot of our data, statutory issues that govern our data, and at the same time know and understand how to leverage it for big public health concerns that can influence policy and decision making in real time is something that can be very important. And I don't know if it needs to be a separate degree or with specific concentration or certain training in that area or education in that area, which could be a degree also, to be able to serve that purpose. That is something I can see partners in the state contributing so that we can build in this workforce the type of people that are best suited to be able to answer those questions. I think a lot of times we focus and need to rely on the private sector and people that have been doing informatics in other areas to be able to deal with this at the level of state government. I know the CDC is working with, for example, Chickasaw, which is a third-party vendor as well. And I believe that they have a number of informatics type people that they bring in who the states are able to leverage as well. But that type of training and that type of skill set is something that we're going to need in our workforce going forward.
Wonderful. And hopefully we can help with that process. The other question I would have is, as you look at the stuff that Adi has presented earlier and, the collaboration and data exchange with the CDC, I know that's an area where, again, privacy concerns are there, but what do you envision kind of going forward with data exchange, with the CDC, your public health partners at the national level?
So right now, the real-time example that we see really every day is on COVID. And the CDC is using the community levels, the COVID community levels, to really help guide us on how much transmission is occurring and how much the disease prevalence is impacting our communities and our hospital systems. And that is going to continue to evolve as how we monitor COVID evolves in the months and years ahead. And I can see this expanding to many different areas. And there's always been some level of data exchange that occurs with the federal government. But as we need these data to impact and influence both their policy decisions, whether it be on any number of topics, including COVID, and then how that relates back to the data we have on the ground, I very much envision that our work with the federal partners, and particularly with the CDC, is going to be very critical for us being able to see how policy decisions that they make impact us and vice versa.
So now we got that wonderful recording from Commissioner Giuttani. We're gonna just move on to the next slide. And in that next slide, we're gonna share some examples of what happens in other states through a health information exchange at the state level, and how they leverage their HIE for public health use cases. So in Maryland, for example, they utilize their public health their information exchange to share data around their prescription drug monitoring program. They also will use it for actually sharing results for point of care testing and vaccinations and results for COVID. So they use that infrastructure to report on those things. They also can utilize it for registries such as colorectal screening and things that are occurring at a statewide level to just understand what's happening in the public health arena. And then they can utilize it for purposes of evaluating individuals who have HIV or AIDS and are lost to care, and whether they're utilizing medications or not. And of course, these are all done in a private, secure fashion where you're not releasing individual data necessarily, but public health data only. And then obviously there's information about in children, WIC access, and whether or not a child has a very low birth score, and there's challenges there. And all that can kind of be presented in graphical ways that help people understand differences across the state. So this is just a set of very small examples, but maybe in one of our future webinars, we can kind of go through what's possible in the future. I do want to get the next slide, because we want to actually share with people that there is a way to contact us and for questions. And I do want to raise one question and have Adi and maybe Miriam answer it while we're going to the last slide there. And that is a question from Jen Sarles, who's the executive director for our HIE. And she notes that they both mentioned that that the reasons that there's some challenges with funding, and she wants to know the reasons that there's silos of data at the state and federal level, and did it stem from funding restrictions, and how is that being addressed, I guess, in the data modernization? So Adi, if you want to take that on.
Yeah, absolutely. First of all, it was amazing to hear Commissioner Giuttani's talk on this. I mean, it mirrored and really is the complementary yin and yang of what we're hoping at the federal government. So, and the lifeblood is at Connecticut. So thank you for that. We should definitely take this on a roadshow. I think the issue about funding is, and that's going to be coming out in the next few months in terms of federal government looking at that. And what we're hoping is to have more of a shared vision in how the funding would be used and spent, et cetera, and all of that. And that, I think, is so important, so that we can help we can all learn from the experiences such as Connecticut's to be able to say what are the best practices so that we can have interoperability between what Connecticut sends us and then all the other jurisdictions, etc. So I think stay tuned for that. Beyond that, I won't be able to say anything specific, of course, about funding. There are many other folks at CDC who we can put you in touch with on that. But again, thank you for the opportunity here, Tom. It was wonderful to visit with all of you. Over.
And Miriam, and would you like to say anything in terms of responding to both Adi's question, statements as well as the presentation?
Yeah, I mean, I think I would just add, and I'll give my perspective, and that might differ from how Commissioner Giuttani would answer this question. But I think historically, public health has been underfunded, and with that lack of investment, we weren't able to keep up with the technological advances that many others were able to keep up with. And I think now that we have all this funding because of COVID and people see the value in public health informatics and surveillance, now we have to figure out how to spend it and in what areas do we need to prioritize catching up. And, in Commissioner Giuttani's discussion, you saw how many people we're hiring, and it's almost that like we can't hire fast enough to spend the money to make the technological advances that everyone wants to see. But it's an exciting time to be doing this work. And I think, with monkeypox looming, we're taking a lot of our lessons learned from COVID to prepare for that. And, I think we're definitely ready for future public health outbreaks and excited about the work that we're doing.
Oh, Miriam, don't tell me there's going to be another one.
Hoping not. There's no cases in Connecticut.
There's no promises out there, and that's why we need to be able to do this and do it effectively. And I think that we just had a wonderful presentation by our presenters, and I really appreciate that their time. And I know there may be other questions. You can send them to us, and we will pass them on and get them back. There is, for continuing medical education, there will be information sent to those who requested it via email afterwards, and continuing pharmacy also will receive a email afterwards, and there is a session code that needs to be placed. And you do have 2 weeks to access and complete the evaluation. But I really want to thank our presenters, and I think I've learned a lot in this process, and I'm sure what we've done is hopefully create additional collaborations and opportunities to kind of move things forward. So thank you all.
Thank you. Stay safe, everyone. Bye-bye.
Bye.